Welcome back. This is video number 4, dual injection. In the first video, where is the stump? Is it LED or diagonal artery? What is the length of the occlusion? In the second video, is it post-CTO RV or RCA? What is the length? Is it tortuous? Is it 1 or 2 levels of occlusion? In these cases, can we answer these questions if simultaneous antegrade and retrograde injections? Today's topic is about dual injection. In this video, we will answer the following questions. When to do dual injection? Are the questions answered? Is there benefit? Which revascularization strategy? PCI versus CABG, or just the medical treatment? How to do it, and what are the common mistakes? Case number 1. Male patient with anterior ST elevation myocardial infarction. Left main injection showed tight lesion in the LED or diagonal artery. Where is the stump? RCA injection showed retrograde filling in the LED. What is the extent? The distal retrograde flow was competitive. If simultaneous injections in the RAO cranial, can we draw the LED? The LED course appeared with dual injection, with appearance of another significant LED lesion after the diagonal artery origin. Wiring the lesion was guided with retrograde injection. Because of the wire, there is absence of flow or pressure against the retrograde flow, so there was no need for dual injection during wiring. And PCI was done. Explanation. With antegrade injection, there is more flow in the early diagonal artery and septals, low resistance, followed by less flow across the lesion, high resistance, then post-lesion diagonal artery steal, followed by absent stump and course of LED. While with retrograde injection, there is more flow across the septals, low resistance, followed by less flow across the distal origin collaterals, high resistance and long distance. There was dye fading before reaching the LED stump. While with dual injection, there is less flow across the septals due to high resistance due to flow from both sides, followed by more flow proximal to the lesion and retrograde collaterals. So the LED course and lesion appeared. Actually, it is dual LED, with short LED giving origin to mid-septals and a long LED giving origin to diagonal artery and distal septals before continuing with retrograde collaterals of RCA. Case number 2. With antegrade injection, we have LED C2O. What is the level of occlusion? Is it anatomical or functional occlusion? With retrograde RCA semi-selective injection showed a retrograde flow through conus artery to the LED just after the CTO segment. It reached the distal cap of the CTO segment. With dual injection, the flow reached from both sides the whole CTO segment. Explanation. With antegrade injection, there is a tight ostial and proximal LED lesion, with no enough flow and pressure left to cross this lesion. With retrograde injection, most of the collateral flow reached the less resistant mid and distal LED with more opacification, and less flow to the more resistant proximal LED lesion, which showed less opacification. While with dual injection, there is simultaneous increase in pressure from both sides, allowing flow in the lesion. It was a significant lesion with functional occlusion. Wiring was done guided with the retrograde injection, followed by stenting. Case number 3. With antegrade injection, there is proximal RCA C2O lesion. The post C2O segment shows a very faint antegrade flow. Is it RV or RCA proper? What is the length? Is it 1 or 2 levels of occlusion? Is it a tortuous course? While the retrograde injection shows a normal left system. LAO cranial view was taken to search for the retrograde filling to the RCA. Retrograde filling to the RCA was very faint. Same questions not answered. Yet the dual injection answered the questions. With simultaneous pressure in both sides of the lesion, there was an acute angle at the end of the segment, tortuous course, and only one level of occlusion. It was an RCA proper, not an RV branch, since continuation from the PDA. With 2 single injections, JC2O score was not detected due to absent data regarding the length or bending of the segment. Yet, with dual injection, JC2O score was detected. It is 1 due to presence of acute bending at the end of the segment. Case number 4. Antegrade injection showed a mid-RCA C2O lesion with appearance of ipsilateral retrograde collateral flow to the PDA and up to mid-RCA. Collaterals was through proximal and distal RV branches. The proximal RV branch to the septal artery, yellow arrows, yet with no continuation proximally due to competitive flow, and distally, yellow braces, while the distal RV branch, red arrows, continues to the RCA. Retrograde injection showed a normal left system with faint contralateral retrograde collaterals to the PDA and distal RCA, not the mid RCA. Collaterals was through distal and proximal septal collaterals. The distal septal collateral reaching the mid PDA was capacious with good angle entry in the PDA, while the proximal septal collateral reaching the PDA very proximal with good angle entry in the PDA, yet not capacious and late in appearance. With dual injection, both contralateral and ipsilateral retrograde collaterals to the PDA and mid-RCA appeared. The proximal retrograde collateral, which was faint, late, and not continuous with the retrograde injection only, red arrow, is now early and capacious only with dual injection due to filling from ipsilateral proximal RV branch, contralateral mid-septal branch, and mid-RV branch to some degree, yellow arrows. There is full continuation proximally to the LED and distally to the RCA, yellow braces. Dual injection changed the plan of C2O PCI approach. Contralateral proximal septal collateral, which was the third line of approach with separate injections, is now the second line with dual injection. This route is considered second line for C2O PCI approach after proximal antegrade approach, guided with dual injection, not only the retrograde or ipsilateral injections, through the septal entry, not the RV epicardial entry. Case number 5. With antegrade injection, there is ostial dominant CX lesion with total mid-LED instant restenosis without any distal antegrade or ipsilateral retrograde flow, except for a very faint distal ipsilateral retrograde apical LED filling. With retrograde injection, collateral flow to distal LED appeared, with competitive flow in the mid-LED segment. The post-stent mid-segment, yellow arrows. Is it true occlusion, part of proximal C2O, red arrows, or functional occlusion due to proximal CTO impairing flow distally and causing competitive flow distal to it. With dual injection, the length of the segment is the same. With retrograde injection, RV diagonal artery collateral appears. Only after antegrade injection, its continuation to the LED proximal to the occlusion appears. This is due to increased proximal pressure in the LED due to the mid-CTO and increased resistance of flow in the septals from the flow from the RCA. In this case, CT was not helpful to describe the artery post-stent. With dual injection, there is increased intra-arterial pressure distal and proximal to the segment and in the septal wall. If the occlusion is due to decreased proximal flow, there would have been some flow in this segment, yellow arrows with dual injection. Now it is confirmed that the post-stent occlusion segment is not a functional occlusion due to decreased proximal flow. It is rather a post-stent CTO, especially with no nearby septal filling, yellow brace, and this was in favor for Kabish during heart team discussion. Case number 6. Antegrade injection showed a mid-RCA C2O lesion. Is it mid or mid and distal RCA CTO lesions? And the distal lesion, is it functional or anatomical occlusion? With retrograde injection, there was retrograde filling to the PDA and posterolateral artery. Flow reaching the distal RCA, not the mid RCA. With retrograde injection, there is a long C2O lesion with a mid-island which appeared in the antegrade injection. With dual injection, the picture is different. The distal C2O level was just a diseased segment. With dual injection, there is simultaneous increase of pressure from both sides, leading to flow in the distal segment. JC2O score using two single injections. Level 1 occlusion, red arrows, score is 1 due to long lesion, while level 2 occlusion, yellow arrows, is mostly 0. With dual injection, only one level of occlusion, score 1 due to long lesion. Case number 7. With antegrade injection, there is mid-RCA CTO lesion, while with retrograde injection, there is a diseased left system. With retrograde injection, there is a faint retrograde flow to the posterolateral artery, PDA, and acute marginal branch. With retrograde injection, the flow in the acute marginal branch nearly reached the RCA. With dual injection, the mid-RCA C2O lesion appeared short. The retrograde flow is from the acute marginal branch to the mid-RCA, then the distal RCA. With dual injection, there is increased intra-arterial pressure distal and proximal to the segment. Note that the flow in the distal RCA didn't appear except after the antegrade injection, obstructing any unseen retrograde flow in the C2O segment. Although there is no simultaneous arrival of dye to both sides of the distal C2O segment, since flow in both sides was from the retrograde injection, yet it was assessed in a different view, LAO cranial. With two single injections, JC2O score showed one level of obstruction, yellow arrows, score 1 due to long lesion. While with dual injection, two levels of obstruction, JC2O score, each level is 0. Case number 8. Antegrade injection showed a mid-CX-CTO lesion with no distal antegrade nor ipsilateral retrograde filling. Is it a small ramified CX proper after giving origin to a large OM, or a true CTO lesion of CX and with many originating branches? With retrograde injection, although there was a large posterolateral branch, there was no flow reaching the distal branches of CX. The retrograde injection didn't answer the question. With dual injection, there was distal filling. With dual injection, the question was answered. It was a true CTO short segment of a long precious distal OM. This increased the likelihood of success of CTO trial.